let's discuss torsion of the testis. This is the most important topic for NEET PG, NEET SS, theory examination, even practical also. Okay, so my reference will be latest edition of Bailey, Sabiston, and few points from Swartz also. So, definition: the twisting of the spermatic cord and its content, such that it leads to decrease in testicular blood flow. Okay, so it's a surgical emergency. So like this, if it twist, so decrease in blood supply. Okay. So regarding pathophysiology, so there are two types: extravaginal torsion and intravaginal torsion. Okay, so extravaginal torsion seen in neonates because the tunica vaginalis is not yet developed fully. So extravaginal torsion seen in neonate, it's lead to increased mobility of the testicle before descent into scrotum. Okay. And beyond this age, tunica intravaginal torsion occur mainly in adolescents. So pathophysiology regarding intravaginal torsion. So there are three mechanisms. One is bell clapper deformity, a clapper in a bell deformity, same thing. Then inversion of the testis, and third one is separation of epididymis from the body of the testis. Okay, so a clapper in the bell is because of high investment of tunica vaginalis. Okay, so this is most common in adolescent, and typically this is bilateral. B for bell, B for bilateral. Okay. And in inversion of the testis is rotated and transversely or upside down. Okay, and third one is separation of epididymis from the body of the testis. Okay, so the role of cremaster in testicular torsion: the spiral attachment of the cremaster favor the rotation of the testis. Okay, so sudden contraction of the cremastic muscle during mechanical, sexual, or thermic stimulation may lead to torsion. So in mechanical, straining at stool, lifting a heavy object, and sexual activity, sports can precipitate this condition. Okay, so there are two main factors determine the damage of the testis: the extent of the twist and duration. Okay, so extent, if the more twist, more damage. So with respect to 360, 370 degree cause more rapid ischemia. Okay, or regarding duration, if you untwist within 6 hours, it will lead to 100% salvage of testis. So salvage as 6 hours. Okay, or 20% in 24 hours. Remember, 24 hours, 24%. Simple. Occasionally, testis untwist spontaneously without surgical treatment. This is seen in intermittent testicular torsion. May ask somewhere. So, regarding clinical feature, the age group is 10 to 25 years, and the peak incidence is 14 years. Okay. So if you patient will come with the complaint of sudden severe pain in the groin, generally unilateral. Okay, and patient feel nauseated and may vomit, and on examination you will see scrotum is swollen, tender, asymmetric, and testis is high riding in position. Okay, Generally there is no pyrexia, and the cremastic reflex is lost. So this is most consistent finding. Okay, out of all this, cremastic reflex is lost is most consistent finding. So there are so many differential diagnoses, and how you are going to differentiate between these differential diagnoses. So the first one and the main is epididymoorchitis. So elevation of the testis reduce pain in epididymoorchitis, but worse in torsion. You just remember the testicular torsion pain cannot be reduced by elevation or any maneuver. Okay, okay. And epididymoorchitis, we give scrotal support so that patient feel less pain. Okay. So torsion of the testicular appendage. Next is torsion of the testicular appendage. Next DD. So there are appendix of the testis. This is also called hydatid of Morgagni. Okay. So you will see in if the torsion of this appendix, you will see small dark spot, or this is also called blue dot sign. Okay, in scrotal wall. So diagnosis is made clinically, and there is a conservative management. If in doubt, you have to explore and remove the untwisted appendage. Okay, there is no untwisting. You have to remove the that torsion appendix. Okay, okay, okay. Bit this theory also given in some other places of belly. So I want to discuss bit here. So already told, the intravaginal is also known as bell clapper testicular torsion. It's because of abnormal posterior anchoring of the testis. Okay, so edema and erythema appear later. Okay, okay. So in extravaginal torsion mainly seen in newborn with 70% prenatally. Okay, so emergency neonatal exploration remain controversial since salvage rate are low. Okay, so mainly I want to discuss this one. Okay, so appendix of, there are two appendix. One, actually there are three. The one appendix one in right iliac fossa. Okay, that appendix. Okay, leave it. Next we have two appendix in scrotum. One is appendix of the testis and appendix of epididymis. So both are remnant. Okay, so one which is on testis is remnant of Mullerian or paramesonephric duct. Okay, the one which is mainly responsible for female genital system. So on testis we have remnant of Mullerian or paramesonephric duct. Okay, whereas appendix of epididymis is Wolffian or mesonephric remnant. Okay, okay. So these both are seen on upper testis or epididymis respectively. So appendigeal torsion mainly seen in 7 to 14 years of age. So bit earlier than testicular torsion. Okay, and pain is also less, mild to moderate acute scrotal pain, and there is generally there is no vomiting. Okay, so favorite question is blue dot sign. It's seen in appendigeal torsion. So if you are in doubt, you can do Doppler ultrasound to exclude testicular torsion, and the treatment is analgesia and rest. Okay, if there is equivocal cases or severe pain, okay, or diagnosis in doubt, you can go for exploration. Okay, okay. The next one is idiopathic scrotal edema. Okay, so age group is 4 to 12 years. Scrotum is very swollen and little pain or tenderness. Okay, and swelling is bilateral. This swelling can extend to perineum, groin, and penis, and this is mainly because of allergic phenomena and eosinophilia. Okay, and the last DD is strangulated inguinal hernia. This is also, and the one more DD is mumps orchitis. So in this, cord is generally not thickened and this is bilateral condition. So this is picture of idiopathic edema of the scrotum. Okay. Okay. So regarding management, mainly determined by the clinical grounds. While Doppler ultrasound can aid in your diagnosis, in Doppler you will see the uh, blood supply. You will confirm whether blood supply is present or absent. So very high false positive is seen. So that's why this is not routinely recommended as per Bailey. Okay. So diagnosis, urgent scrotal exploration. Okay, and the window period is 6 hours from onset of the pain. Okay, if you want to salvage the testis. Okay. The exploration of the testis can be performed through transverse or midline scrotal incision, so that we can approach both sides. Okay, if the testis is viable, it should be untwisted and fixed with 3 non-absorbable suture. 3 non-absorbable suture. Okay, okay, and the where you are going to suture? So tunica albuginea of the testis and scrotal raphe. Okay, in Swaz it is given fixed to the dartos fascia with a small non-absorbable suture on their medial, lateral and dependent aspect. Okay. Okay. And what about other testes? Okay, this should be also fixed. Okay, because of the anatomical predisposition likely to be bilateral. Okay, if there is a clinical doubt of testicular viability, you can wrap the testis with the warm swab, or you can also do a small incision over the tunica albuginea and you will see bright red arterial bleeding. Okay, so this is viable testis. Or in, if this is testis is gangrenous, so you will remove the testis and later you can put the prosthetic replacement. Okay. Okay. So this is Doppler of testicular torsion. There is no blood supply. Okay. Okay. Let's see what is given in Sabiston. Sabiston says the peak incidence is 14 years already told. Okay. Acute scrotal pain is primary symptom. Okay, and high riding and edematous and significantly tender scrotum. The one, if you see in question, if you see, they ask very specific diagnostic test. Specific word is mentioned. You can mark radioisotope scanning. Okay. Okay. An immediate surgical derotation through the scrotal medial raphe approach. Scrotal medial raphe approach. Okay. Okay. So in neonate, the inferior aspect of the testicle is attached to the scrotum by gubernaculum. Okay. So if the torsion occur, the testis is subjected to warm ischemia. Okay, warm ischemia. Okay, and Sabiston says irreversible damage begin as soon as 4 hours. Okay, and complete by 8 to 12 hours. Okay. Already told, most consistent physical examination finding is loss of cremastic reflex. Okay, best confirmatory is radiological study is color Doppler ultrasound. If you see the confirmatory, you will mark a Doppler. If you see specific, you will mark radioisotope. Okay. And so if you suspect testicular torsion, no need to delay scrotal exploration to obtain imaging. Okay. And incision already told, midline or transverse scrotal incision. If the patient come to you of late suspected late testicular torsion, even you go for urgent exploration, there is still chance of viable testicle. Okay. Okay. So this much regarding testicular torsion. Thank you.